will be a Q&A at the end of the presentation, so if you have questions that come up as we're going through, by all means put them in the chat and we'll be watching for those. And at the end of the webinar there will be a short survey, and we'd love it if you could take a few minutes to complete that. You know, your feedback is valuable and it helps us improve future webinars, so thank you in advance for doing that. With those little pre-announcements, let's get into it. As I do these kind of little introductory slides, I would encourage you to introduce yourself in the chat, maybe share a little bit about what you do. So this is, as I said, Innovation and Opportunity in Community and Primary Healthcare. It is the Health System Leaders webinar number 4. So this webinar is part of a series of webinars. If you haven't seen the other ones, you can check them out. You can check out the recordings on demand anytime at leadershipproject.ca. And these are, this series is really meant to provide foundational customized content on the systems and policies that impact health leaders on a daily basis. So we've been getting great feedback about those. If you haven't seen them, by all means, check them out. Our agenda for today, maybe I'll start by just introducing myself. I'm Sandra Kahale. I'm a communication strategist who's been working with leadership since the beginning, and I'm a huge fan both of the project and of the people involved in it. So I'm very excited to be part of this today. And what we're going to be looking at specifically today in terms of an agenda is we're going to start by looking at kind of the leadership vision. And then we're going to go into a little bit of a big picture look at you know, where the partners sort of come from, what parts of the ecosystem are represented here, and all of that is leading us into a panel discussion, which I'm really excited about, on leadership perspectives on innovation and opportunity in our ecosystem. And then we'll wrap it up. We hope to have time for questions, and we'll take it from there. So I want to start in a way at the beginning, which is this idea that leadership matters. You know, these webinars and the entire leadership project reflect the fact that now more than ever, community and primary healthcare sector needs effective dynamic leadership. And that's true not only to support the government in its commitments around health, but also to produce better health outcomes across the system. So community and primary healthcare will be particularly key in increasing access and reducing wait lists and keeping patients informed and engaged and empowering frontline workers. And that's really what LeaderShift is all about. Our mission is to develop current and future leaders with the capacity to support collaborative, outcome-focused transformation of the healthcare system. And our vision ultimately is to foster collaborative partnerships that strengthen our network and allow us to work more effectively across the ecosystem. And that vision is actually embodied by how LeaderShift is set up. It's a partnership between Community Health Ontario and the Association of Family Health Teams of Ontario. So inside Community Health Ontario, we have Addictions and Mental Health Ontario, Alliance for Healthier Communities, Canadian Mental Health Association of Ontario, and the Ontario Community Support Association. So in a real sense, LeaderShift itself is modeling the kind of collaboration that we're looking to foster. So let's jump right into looking at the big picture here. You know, collaboration is like carbonation for fresh ideas. Working together bubbles up ideas that you wouldn't have come up with solo, and that gets you further faster. And when we're talking about fostering collaboration, what we're really talking about is the idea of breaking down silos and thinking as a system rather than as, you know, disparate pieces. And what that requires is that we all have an understanding of the ecosystem and what it's doing, what the different parts of it are doing. So I want to start kind of leading into the panel discussion that we're going to be having by taking a quick look at the partners and the pieces of the ecosystem that are represented by the partners, where the panelists are really coming from. I'm going to go pretty quickly through this next little bit. If you're trying to take notes, fear not. A copy of the slides will be available after this webinar is over. So let's start with taking a look at community-governed primary health care. You know, this is an area where we're combining primary care, health promotion, and community development activities. Organizations working in community-governed primary care are overseen by boards that represent and are accountable to the community. And the kinds of organizations that we're talking about here are things like Aboriginal Health Access Centers, community health centers, community family health teams, and nurse practitioner-led clinics. Inside of those organizations, you get quite a diversity of professionals working together. So they might include physicians and nurse practitioners, registered nurses, dietitians, physiotherapists, social workers, indigenous traditional healers, health promoters, community development and outreach workers, as well as system navigators and social prescribing link workers. And the kinds of services that are offered through community-governed primary health include things like seniors programs, group programs for young parents and newcomers, exercise and nutrition programs, community initiatives like community gardens and others. And these services often prioritize the needs of people who have faced barriers to healthcare. For example, Indigenous people, Francophones, racialized, and LGBTQ communities. Community-governed primary health care contributes to the system by advancing access to team-based care, providing person-centered care, improving transitions, strengthening connections between primary care, mental health, and community services, for example, through social prescribing, and connecting people to the health system and creating healthier communities. So that's community-governed primary health care. This is often looked at kind of as part of together with team-based primary care, but we're splitting it out here because we've got representation from both, and we want to sort of tease out some of those distinctions. So here in team-based primary care, teams are working together to manage the whole patient and help people stay as healthy as possible. Team-based primary care serves over 3.5 million people in over 200 communities across Ontario, and it does that through 187 family health teams, 75 community health centers, 25 nurse practitioner-led clinics, and 10 Aboriginal Health Access Centers. The teams in these organizations, again, can include a wide range of healthcare professionals, family physicians, registered nurses, registered practical nurses, chiropractors, occupational therapists, pharmacists, physiotherapists, registered dietitians, respiratory therapists, social workers, and others. And they really focus their services on the needs of the particular communities that they're serving. Some of these do serve populations with specialized health needs, so homeless or Indigenous or newcomer or racialized or religious communities. In terms of the contribution that team-based primary care makes to the health system overall, it increases the coordination of services, so there's more seamless transitions for patients and families. It reduces duplication, increases quality of care and facilitates access, and reduces costs and contributes to better value overall in the system. So that's team-based primary care. From there, let's take a look at home and community support. So home and community support services help people, including seniors and people with disabilities or chronic illnesses, who need care in their own home, at school, or in the community. And the idea here is to empower people to live independently in their own homes for as long as possible, and also to defend against decline and the development of more serious needs in the future. Organizations in the home and community support services space tend to have very deep roots in their local communities. And the services that they offer are delivered by a variety of professionals who might include nurses, personal support workers, physiotherapists, occupational therapists, speech therapists, social workers, homemakers, and others. Again here, the specific services are going to be very tailored to local needs. And they can include things like home care, nutrition programs, transportation services, respite and adult day programs as well. Home and community support benefits the health system overall by preventing unnecessary hospitalizations and reducing emergency room visits and curtailing premature institutionalization. The sector is also currently working to improve the client experience and break down silos across sectors through programs like transitional care that help ensure a more seamless client journey from hospital to home. Finally, let's take a look at addictions and mental health. This part of the system serves approximately 500,000 Ontarians experiencing mental health or addictions challenges annually with a wide variety of programs and services. They work with diverse clients who can come through primary care, for example, through physician referrals, or be transitioning from more acute care like hospitals. Programs are delivered by community agencies and sometimes through hospitals or health clinics. Again, this component of the health system brings together a diversity of professionals that are working together to provide a range of services that can include things like counseling, treatment, psychotherapy, and elements of primary care such as nurse practitioner-led clinics. The kinds of services that we see in mental health and addiction services include addiction clinical supervision, supportive housing, residential addiction treatment, case management and counseling, peer and family support, employment programs, withdrawal management, and community treatment. Community-based mental health and addictions adds value to the health system by providing comprehensive accessible care, bridging transitions, and strengthening connections between primary care, mental health, and community services, working with partners like physicians, hospitals, and other providers to provide a coordinated continuum of care. So that gives you a sense of where the partners are coming from, and it sort of leads us into an introduction of our panelists today. So our panel is going to be focused on innovation and opportunity, and we've got a great lineup for you, starting with Camille Kenville, who's the Chief Executive Officer of the Canadian Mental Health Association Ontario Division. Before joining CMHA Ontario, Camille held senior leadership roles in the educational, governmental, and children's mental health sector, and she served in senior roles at the Ministry of Children and Youth Services, Children's Mental Health Ontario, and the Ontario Public School Boards Association. We also have with us today Kavita Mehta, who's CEO of the Association of Family Health Teams of Ontario, a role that she has been in since 2016. Prior to this, she served on the board of directors and was elected as the first non-physician president and chair in 2012. She was previously a senior program consultant at the Ministry of Health and Long-Term Care Primary Healthcare Team, where she participated in the policy and program development work for family health teams and primary care renewal. Adriana Tedley joins us from the Alliance for Healthier Communities. She's the Chief Executive Officer and has over 35 years of experience in advocacy, public administration, community development, financial and staff management, policy, and board development. Her work in government, the labor movement, and several community-based associations has focused on issues related to healthcare and the determinants of health. Joining us today, we also have Deborah Simon, the CEO of the Ontario Community Support Association. Her background includes work across the health sector in acute care, long-term care, and the rehab sectors. She's worked with the government as the nursing coordinator for the Ministry of Health and with planning bodies on the board of the District Health Council in Durham Region. She's also a registered nurse. Adrienne Spafford joins us from the Addictions and Mental Health Ontario, where she's the CEO. She has 15 years of experience in public policy, advocacy, communications, and stakeholder relations, and she's held senior positions at the Ontario Long-Term Care Association, the Canadian Breast Cancer Foundation, the Ministry of Health and Long-Term Care, Infrastructure Ontario, and with the Office of the Premier of Ontario. So welcome to our illustrious panel, and thank you all for joining us today. Let's jump right into it, and I'm going to invite the panelists to each of them to answer this question in turn. Our first question is going to be, from where you're sitting, where do you see the biggest opportunities right now? And for those of you who are listening on the webinar, feel free to participate in this discussion in the chat, either with questions or comments or with your own insights on where you're seeing the biggest opportunities from where you're sitting. So with that, let me turn it over to Camille. Camille, where do you see from where you're sitting the biggest opportunities right now?
Thank you, Sandra. You're just doing a fantastic job on this webinar, and I'm really delighted to be part of it today. And I really like this question. I have to say, there's so much happening across the health system right now, and there's a fair bit of anxiety as we look at Ontario health teams and the major changes that are coming our way. And I think sometimes it's useful to stop and say, there are opportunities in all of this, what appears to be mass confusion at the moment. And I think it's good to really focus on what we can do and do well. And I think there are a number of things that we can be grateful for, recognizing that, of course, my filter or my worldview relates to community-based mental health and addictions care. I would just say that with respect to my sector, I'm really excited about the possibility of having better engagement across the system, the healthcare system generally, and how our services could be embedded into that system. I see in the very near future greater collaboration, in particular with child and youth mental health, which many of you know is now part of the Ministry of Health and Long-Term Care, where it had never been before. So that could give us the opportunity to look across the lifespan and develop services that are really relevant to individuals wherever they are in their lifespan. So in addition to that, we've talked about it on this webinar, but integration with primary care, again, really new and unique opportunities as it relates to how we are working with primary care partners. And how are we looking at linking, speaking of primary care, how are we linking physical and mental health care? And that's something that my organization, and I know AMHO has done excellent work on this as well, very interested in ensuring that individuals think about their health in its entirety, not just their physical health or just their mental health. And so really being able to work and collaborate with partners to really push the envelope on that, which I think has the added benefit of reducing stigma. So new opportunities there and new partnerships there for sure. On a practical note, I look forward to having the chance to keep people in community and not in the hospital. We know that's been a big push for this government when they talk about hallway healthcare. My personal view is that from my experience and that of my branches, I think individuals really want to be served in community. So how can we work with our hospital partners in a new way under an Ontario Health Team model to make sure that folks are getting the services they want where they want them, and not ending up in emergency departments or worse, in ALC beds. And then again, on a practical level, how are we embedding the standards that we really cherish in this sector? We very strongly believe in quality improvement. We've done an awful lot of work on that front. We genuinely believe that that is critically important moving forward. So how do we ensure that that's in keeping with system approaches across both physical and mental health? And how do we embed those standards to ensure that our work is continually improving and that we're offering the best care possible? So I think that's it in terms of structural for the sector, but of course there are other areas as well. So what are the opportunities for leaders? I would say you don't have to be a CEO to take advantage of what's happening right now in healthcare, and I would encourage everyone to step up, and that includes clinical leaders and those on the front line and everybody who has an opportunity to be a part of this change and to really be thinking about what they're doing and how they're doing it, to show that leadership, because I genuinely believe that we will all learn a great deal in this process. I had the opportunity just this morning to hear from healthcare leaders who had experience in British Columbia where they've been through this, and it is a fantastic learning opportunity, and they had great lessons to tell. And it was just a further reminder that we all have a role to play in this. I think clinical leaders in particular will have a much broader view of working with other clinicians in other sectors. I think even our board volunteers who are really, step forward and really simply want to donate their time and energy, they too will have a really different experience, and I hope a very positive one in all of this. And at the end of the day, I genuinely hope we can raise our sector profile and the importance of community-based mental health and addictions, but it will take everybody to do that without question. So those are some highlights, Sandra, and I'm really pleased to be sitting beside my dear friend Kavita Mehta, so I will just pass it to her for her thoughts.
Thank you, Camille. Camille already spoke quite eloquently around a lot of the changes, and I think that as everyone knows, we are in a period of significant health transformation, something we have not seen in decades, and the only way integration is to allow for better transition of care for our patients to actually happen is if there is trust between all of the health and social service partners. And we know that trust is based on relationships, which is foundationally based in leadership. Smaller, nimble, and community-driven organizations like our collective partners have had to be flexible and creative while continually providing exceptional patient-centered care, even when budget increases are not available or when there is, as it currently exists, a shift to an acute-centric narrative. So what's the biggest opportunity? I think the biggest opportunity right now is for the sector to step up. You have stronger and more cohesive relationships than those in other parts of the system. And that cohesiveness will highlight that is not just partnerships and collaboration going on, but that there's been concerted efforts towards integrated care for years. Only 20% of care is delivered in the hospital setting at a given point of time. We know that patients would much prefer to have care closer to home by the people they trust the most. Highlighting patient stories will be important to showcase the necessity for primary and community care to lead the transformation. And doing more for less, though not sustainable and not the right approach, has been the mantra for non-acute care for years. Use those years to highlight how efficient your organization has been to the delivery of care and how high patient satisfaction is with the care despite all the challenges you've had to deal with in the system. I think I just want to end, I'm going to be short because there'll be other opportunities to speak later, but from one of our member teams in West Durham FIT, they won a Bright Light last year or 2 years ago, Bright Light Award, which is an award that are highlighting really great practices, some lessons that they're learning in their local setting, and they won one for governance and leadership. And the title of their initiative was Leadership is not about a title or a designation, it's about impact, influence, and inspiration. And I think that's something that all of you actually have in spades. So I'll turn it over to Adriana to reflect as well.
Thank you. Certainly, I'm glad I'm in the middle and not the end of this because there's a very common theme that is growing across. Certainly, Ontario Health Teams is one of the key themes, and I'm going to focus on that, and also trust, which Kavita spoke to, which is so elemental to what we're doing. We're actually in a very interesting time in Ontario with this government giving us an opportunity to do a very large experiment, and we're not just sure what the road will look like in a couple of years. In the Ontario Health Team, it is very much calling on us to be system leaders and to do system transformation. So that S in leads is what this is really all about. It's called us to develop a connected system, a system of seamless, coordinated care where there's warm handoffs across the diverse partnerships. We all know in our own satisfaction surveys that we get very high rankings. 80% and plus within our system. But where the people are and where the situation that this government is focusing on is actually the warm handoffs between our sectors. And that's really where I'm going to focus today. One of the things that it's calling on us to do is to build trusted networks. And this is a definition of a trusted network that I think we're all called to do on. And that is bringing together a diverse set of stakeholders with differentiated roles linked by a common objective. And that common objective is to build a connected system of seamless coordinated care. And I think that that is actually calling us to do different skills than we've had in the past. Even developing partnerships, which we all talk about, is really a one-to-one relationship. So I'm going to have a partnership with a mental health worker. I'm going to have a partnership with the hospitals. This is actually asking us to collectively come into a room and think together on how we're going to improve the system for everybody. That we each have different roles that we need to respect, and that requires a different set of skills than we've been used to doing. One of the big things that I think we all need to start thinking about is collaborative governance. And what does that look like? Because under the new system, there's not going to be, hopefully, one person in charge. It's going to be a collection of leaders coming together to figure out what is each one of us responsible for and how are we going to collectively achieve that, and how are we going to collectively hold each other accountable for those system outcomes. So there's we talk about leads. I actually think it's taking the S in leads and taking it to another level. It's beyond partnership, and it is about collective governors. It's going to call on each one of you on this phone call to think beyond your own organization, to think beyond the people just walking in your door. It's going to be asking you to think as system thinkers across the whole continuum of care, to put the people of your entire community first. And I think that that's our biggest both challenge and our huge opportunity. If we make this work in the next 3 or 4 years, we will protect community governance. And I know all of us, it's really important about community governance. If we can figure out how to protect community governance at our own local level, work together in a collaborative governance way, meeting the needs of our, advancing the experts and the strengths that we have, but with keeping the system front and center, then I think we will strengthen our organizations, strengthen the system, and improve the outcome for the people that matter most to us. So I think that's a huge opportunity and a huge challenge. So over to Deb.
Thank you very much, Adriana. And I think part of the joy of being on a panel and being fourth out of 5, you get to say ditto, ditto to everybody else, but not to repeat everything that they've said. I think, the first thing I think about with this current, do one's own homework and look internally at the operations that you have and look at new design. You can co-design those processes across transitions and really working closely with clients and caregivers. And a real opportunity to really step up, as some of my colleagues have talked about, to really support the client's optimal experience moving through the whole health continuum. I think there's a lot of strengths in the sectors that we represent, and particularly home and community. I think about it being a sector that is primarily arisen from identifying community need and then using that community engagement to co-design. And I think as we're looking at transformation in the system right now, we don't need experienced consultants to really tell us what really is important to clients in the community. We've worked so hard on that engagement process for so long, long before it was mandated to be patient-centered or client-centered. So there's a lot of experience that could be brought to the table and shared across the system. We've always had a really strong philosophy of consumer choice, and that's one that's really allowed clients to achieve their own goals. And I think this is something that will be seen as a large benefit when you're trying to consolidate and streamline services across a huge health continuum. And also the ability to recognize the right for clients and people to live in their own communities at risk. And that is something that I think has been really a hallmark of the way home and community has worked and existed. I'd say that in terms of thinking about taking advantage, we in home and community have worked extensively with volunteers and caregivers. And when I think about caregivers, certainly 80% of the care that's delivered in home and community is really delivered by the people who are either looking after their loved ones or providing those kinds of support. So I think there's an opportunity for the rest of the system to learn from what the home and community and what community providers do in terms of leveraging that diversity and bringing that to the table. As I think about what leaders should be thinking about going forward, because they've been so extremely close to the sectors that they serve, they actually have a lot to give those Ontario health teams in terms of knowledge about what the communities that they serve need and how these services can be delivered and through, as Adriana has talked about, more warm handoffs and transfers. And I think really in terms of taking advantage of this, it's an opportunity to be present, to be confident about the services that you provide with other health system stakeholders. Community providers have unique perspectives, having worked so extensively with people in the communities and in their homes. Sometimes the data that we have isn't readily tell the full picture, but as I believe Kavita had talked about, the opportunity to share success stories about how to deliver care in the community is a great opportunity. So I will then pass this over to Adrienne, and we'll hear her input.
Thanks very much, Deb, and thanks for having me on the panel. Really, really excited to be here, and I hope that I'll be additive rather than repetitive. It's tough to go last, but I really do want to pick up on something Camille said at the beginning, which is that you don't, I believe very strongly you don't need to be a CEO or an executive director to really be participating in the change underway in Ontario's healthcare system. You can really do that at any level in your organization, and particularly if you aren't a CEO or an ED, you can be sure that your CEO or ED will be very, very grateful for the members of their team that are eager and have energy to come along on this change, because change does make us all nervous as human beings, and I think being willing to get really comfortable with the discomfort and almost embrace the discomfort of change will be a real opportunity. I wanted to talk about really 3 focuses for what I see as the biggest opportunities for leadership development. But again, I'll try not to repeat, is really firstly to focus on the patient-client experience. And I think, much of what's been said before is that community and primary care have a strong history of a focus on a patient-client experience, where, perhaps the acute care sector might be catching up there a little bit with their patient engagement movement. And so that should be seen in this era of the government saying that those warm handoffs and patient-client experience is paramount. That should be seen as an asset to integration from the community sector, and something that you're bringing to the table. I would also say, secondly, focus on quality improvement. This is a bit of, I'm not saying put your head in the sand. That's basically the opposite message I'll be talking about later. But focus on your knitting. Focus on quality. Because in this era of Ontario Health Teams and integration and transparency that hopefully will come to light with outcome data, we're going to be, teams are going to be looking at each other and their partners across the table, and they're going to be looking at quality data. And so now's really the time, and so many of you in the sector have been doing quality improvement initiatives of various kind. That's going to pay off big time in the years to come, I think. And then thirdly, focus on deep relationships and trust. This has been spoken to before, but I think, again, we're looking at a time where the government really is honestly looking at community partners to build relationships among themselves on a grassroots level without something like a LHIN bringing them together. The government's really looking to partners to self-organize and say, this is how to deliver better care across the continuum, across the entire healthcare sector for our patient population. And so that's going to require relationships, and it's going to require trust, and it's going to require taking risks and looking across the table and say, when you say you have money on the table for my organization to do a little bit more, I'm going to trust you that you mean that. I just want to sort of finish on this notion that, I think many of us in the community and primary care sector were potentially a little bit defeated by the narrative in the election, in the provincial election last spring, that felt like it was all about hallway healthcare. At the time they were calling it hallway medicine. Thankfully they've changed the name to hallway healthcare, but that it was all back to talking about hospitals. And, I think we've seen the government acknowledge, and certainly experts acknowledge, and it's something that really the solution to ending the problem, which is a real problem of people receiving care in the acute care system on a bed in a hallway or in a broom closet rather than in a room that lends more privacy and a more suitable environment for care, that the solution for that lies in the community. It lies in primary care. And I think that if the Ontario Health Teams and the model gets to fruition, what that's going to mean is that on a regular basis, there'll be a group of people because there'll be, one digital record per client in the geography. What that means is that there'll be a group of people looking across the table at one another, examining client journeys. And I think that really there'll be a huge opportunity for the business case and the client experience case of the community sector to be shown, because we'll be able to see that by ramping up service in community, we really are, or in primary care, we really are able to reduce usage of the emergency department. And I think that will become a lot more real to members of the Ontario Health team, not just within the community sector, but also within the acute care sector. So focus on patient-client experience, focus on quality, deep relationships, and when you've got access to that data where you feel like you're finally able to prove what you've been saying over and over and over again about how much value add to the system, take advantage of it.
Thank you all so much for those thoughtful and inspiring answers. Great answers and great energy, so thank you. Let's move on to the next question, and I want to encourage those of you who are listening to kind of follow along in the chat if you have answers to these questions too, or if you have questions about the answers that you're hearing. So the next question we're going to focus on is innovation, collaboration, and integration. So my question to the panelists this time around is, how are your members innovating, collaborating, and integrating, and what success stories can you share with us? So, we're keen to hear stories that inspire across the ecosystem here. And so let's start with you again, Camille, on this question.
Thank you, Sandra. I too would love to hear feedback from the folks that are participating in this webinar. I'm sure that without question there are lots of good answers to this question that are out there, and I would be very interested to hear. In the meantime, I will do my job and answer it, and just say that I'm happy to report that there's a lot of innovation and collaboration and integration happening across the community-based mental health and addiction system. And Adrienne Spafford and I, work very closely on these issues, and I think she would agree that we haven't as a sector sat around and waited for the province to overhaul the healthcare system to start innovating and collaborating, and in some cases even integrating. So I'll point to a few, and again, you'll appreciate my focus is, I guess, for the moment, just the branches that I work with on a daily basis and what we've witnessed in terms of what they have done, which we'll take full credit for, even though they did all the work. And just point to, for example, our Durham branch, where they have a nurse practitioner-led clinic on site, and they have really done an extraordinary job integrating both physical and mental health in one location with pharmacists specially trained in mental health and addiction meds. I think it's a fantastic model. Our Windsor branch, by the same token, is co-located with a community health center, and we have a great leader there. She's cross-appointed with Hotel Duke Hospital as a VP in the hospital. So really innovative work that's happened. In London, we have a crisis center where we can divert from emergency departments, hospital and police, police can divert right to the crisis center, ambulances can get to the crisis center. So it's very, very exciting to see these changes that have happened, and I think they're potentially great templates, great models for what could happen across the sector generally. I could point to many examples in the justice sector as well, where a lot of work happens as it relates to those who are in conflict with the law and who struggle with their mental health. But suffice to say that a lot of really neat learnings that have happened. So that's kind of, I would say, a branch perspective at a very high level and quick kind of review. I would say at an association level, I'm sitting here with my 4 other colleagues who do amazing work every day, and I think leadership is really an offshoot of the respect we have for one another and the desire we have to promote those within our sector and to really shine a light on the great work that happens across community and the focus of the best way that we can to support those individuals who give so much of themselves to their work and wanting to see them succeed and have opportunities in future. So I'm delighted to have been part of this from the beginning and really pleased with the work that OCSA has done to lead this work and to lead all of us in it. And I'm beside Kavita, as I mentioned earlier, and AFTO and CMHA had a great exercise last year. We did some work in collaboration at their conference. We had some great outcomes when we talk about linking, again, primary care and mental health and addiction. So, you know, we have, a lot of us have talked about trust, and there's great trust amongst this group, and as a result, great opportunities within it. So I will leave it there, I think, for the moment, and I'll maybe toss it over to Kavita to offer some insight.
Thank you, Camille. I think from the get-go, our members have been innovating, collaborating, and integrating. It is something that you do each and every day in primary and community care, where change is the only constant. And part of that change is being able to adapt and be nimble to continually serve your patients in the way that they want to be served. That could include the introduction of digital health and care, which many teams are doing by using email, virtual care, tablet technology, artificial intelligence, etc. The involvement of your patients and their families in co-design of programs and services. Again, this is very effectively done in primary care and community care, where you have long-lasting, trusting relationships with your patients along the continuum of care, or adapting to new policy changes that have direct impact in the way you provide care, like the introduction of HealthLink, subregions, and now Ontario Health Teams. And I think we have a ton of examples of how teams have been integrating and collaborating over the last decade. For example, the Caroline and Burlington Fits have partnered with Reach Out for Kids in Halton to create a Caroline Families First program, which is a co-designed program between primary care and community-based mental health that uses a shared peer support worker to support a wraparound model of care, which also includes pediatricians and psychologists. Supporting transitions of care, not a new thing, but supporting transitions of care between hospital and home is something every one of our members do. Thamesville, Tilbury District, and Chatham-Kent Family Health Teams have been working with their partners, including the hospital, to reduce ER visits and prevent hospital readmissions by having a shared approach towards intensive case management with the focused needs of individuals with complex needs. With the consistent approach of integrated case management, which was done with many, many players and partners in the sector, including hospital and home care, they were able to see a reduction of 25.9% decrease in hospital admissions and 28.8% decrease in ER visits in short 6 months. These are the great examples to highlight that this work has been done in primary and community care for years and will continue to be done there. The Northeastern Ontario Fit Network, which we affectionately know them as the North Stars, is a collective of 27 family health teams who have agreed on a common set of indicators to track performance for the 9 most common programs across the region. These indicators will yield information that will help improve patient experiences in care, and standardizing these measures allows the teams to make comparisons, collaborate. Really great lessons to learn from was we did a health team and others across the province to adopt. What we do exceptionally well is looking at creative ways to adapt to ongoing changes, but never losing sight about the importance of patient-centered care. So I'm going to move it over to Adriana to talk a little bit.
Great, thank you. I think to me, I'm going to do 2 examples and build on my opening comments about Ontario Health Teams. The example that I want to bring, and I can't take any credit for this work, is Cambridge North Dumfries, who are in the early stages or well along the road for submitting an application as an early adopter group on May 15th. This is a group that's had a trusted network for over 7 years. They have about 28 organizations co-located in one hub. They have a connectivity table that brings police together with social work, public health, all the different sectors when they identify a person who is at risk of falling through the cracks. How do they do wraparound services? They've been doing health links together for many, many, many years. They have a collaborative table called the CEO Lead Action Plan on Mental Health and Addictions, in which they come together as CEOs to look at common mental health issues. They have a collaborative CRIP across the whole area. So you can already see that for about 7 years, they've over time have developed a trusted network. So when the Ontario Health Team opportunity came up, for them this was just a natural next step. They've built a history of trusted relations there. So they've all gotten together as trusted people coming together in a process to figure out how collectively they need to submit this readiness assessment for the Ontario Health Team. They have not yet decided who is going to be the lead. This is going to emerge as time goes along and as they go through the process. So it's pretty exciting. They've already had 3 meetings of governors of over 80 governors from all the different organizations in that community, and they've also connected with over 90 physicians. So that's a great example of the kind of thinking that we're going to need to do. Another example I'll just give shortly, and that is team care, and I'm going to use the same example that was talked about in terms of Windsor-Essex, building on the CMHA CHC in Windsor and the Community Governed Family Health Team in Windsor. They collectively got some funding to provide team-based care to over 100 physicians in the community who have really complex clients but don't know the community services, don't have access to team-based care, and in a short few months they have connected these physicians to team-based care with a focus on mental health and addictions. So exciting. There's over 30 of these happening across the province, and could go on and on about that example, but that's the other example I was going to speak to. Over to Deb.
Thank you. Thanks. No shortage of bragging rights here at this table, but I really believe that in terms of examples of innovation and collaboration, community, has it in spades, and we've been resourceful by necessity, but nevertheless, I think these have been great. Change leads to opportunities, and leveraging some of the past relationships and developing new ones is a really good example of how just one of our agencies looked to support a hospital with some transitional care beds in the community. So it's not rocket science, but they were encouraged by they encouraged the hospitals to really throw their most challenging cases their way. So understanding what services were available in the community, and they were not overly encumbered by allowing clients to live in some level of risk. This agency successfully transitioned a client home that the hospital had in an acute care bed for over 12 years. Apparently it was a remarkable discharge for this client, with people sort of lining up the hallways seeing her leaving the hospital. And it was accomplished through a really high degree of collaboration with other community agencies. So what they did was each agency took a component of the care, but they knit it together through a very comprehensive plan. Where many of us sector leaders may not have the state-of-art technology systems, what they do have in home and community care is really expansive knowledge of the kinds of supports that are needed to allow clients to live independently in the community. And, an example of that would be some of the hub and spoke models of care that we have, and other really great, unique ways of providing support to clients and allowing them choice. And as well, there are lots of shared care, shared governance models that really work. And I think about the Waterloo Wellington network of CSS agencies in collaboration and shared care. And these are emerging all across the system in integrated access. They're very purposeful analytical methods that allow best practice and share learnings amongst partners. So I could brag on forever, but I'll pass it over to Adrian.
Thanks very much, Deb. It is a fun opportunity to brag about all of the innovations you've seen. I'm only 6 months into this role, and a lot of the time that I've spent early on has been visiting members and hearing about the challenges that they've got with limitations of resources, but also hearing from them about how innovative they have been, particularly in the face of funding restrictions. One I wanted to, I'll highlight a couple. The one I wanted to start with was Ridewood Family Services in Ottawa. They recently they were having sort of substantial wait lists for their services, and so they went from a cohort-based intake process where they would only do intake once in the program, and then everyone would have to finish the same cohort before they could intake a new group, to a continuous intake approach, and they've been able to completely eliminate their wait lists. So they don't have wait lists for services anymore. You know, it took really it took a huge amount of effort on part of the leadership team there, and you know, coming back to trust on the part of staff, and a lot of energy on the part of staff, because it meant doing a completely doing their job in a completely different way, where they were used to delivering. I mean, we're sitting here in training right now, so where they were used to delivering training in a very organized cohort and deliberate 1, 2, 3, 4 step way, they needed to really adapt their curriculum so that they could deal with incoming cohort. But one of the benefits they saw not only was the elimination of wait lists, but they also saw that clients, kids who were further along in the cohort, were really able to give a lot of peer support because they were further along in their treatment than people who were coming in earlier on in the treatment. And so the people earlier on in the treatment were able to see the success and the optimism of the people further on in their treatment. So that was a big quality improvement from a system perspective and from a client perspective. Another one I wanted to highlight is just the we're really happy at AMHO with how much more addiction services being delivered through the RAM model, the Rapid Access to Addiction Medicine, or Rapid Access to Addiction Clinic. RAM or RAC are the two acronyms for that. And, you know, where someone, particularly if they're dealing with an opioid addiction, and, you know, we're in the middle of an opioid crisis, and they are looking for addiction medicine like methadone or Suboxone as part of their treatment. Typically, you know, people were coming into withdrawal management, then they were maybe going to another service on the street, you know, just in the community outside of a withdrawal management program to get their addiction medicine, and then a completely separate organization to do a treatment program. And so now with that model, people are having a much more seamless transition between the different steps of dealing with a substance use disorder, and really it's ahead of the curve of what the government's looking for in terms of warm handoff.
Thank you all so much. Those are great answers, and some wonderful models and templates for thinking about you know, how to collaborate and innovate in this space. I hope that got everybody's creative juices flowing. The last question we're going to do is as a rapid fire round, and in basically 1 minute. So I guess we're looking sort of for a tweetable here. In 1 minute, what's something that you've learned about leadership, or one piece of advice that you would share with emerging leaders? And I'm going to start this time. I'm going to go back to Camille. There she is. She's right across the table from me. So I'm going to go back to Camille. Let's hear from you. 1 minute.
Thanks, Sandra. I'm ready to go. I got a little personal on this one. I'll be honest. I kind of thought about it a fair bit, and I want to just, before I start, say I do not have the market cornered on any of these per se, but I think my overall view is that lessons in leadership are absolutely the same as lessons in life, and we should be kind, be fair, be patient. I was not blessed with great patience, so I remind myself to be patient, show respect. And as you know, I work in a nationwide organization, and we have an expression we use, which is, what is the view from the other side of the mountain, which in some cases can be a bit literal across Canada. But in this case, it essentially means you have your version of this story, someone else has their version of the same story. So always be thinking about the context for which others are coming at things, and working with those individuals. I would just finish by saying, if we stay focused on what's most important, which is the client journey, we can all get there. So nothing earth-shattering in any of this, but just life is leadership, and it's all how we conduct ourselves day to day. So thanks, Sandra. Kavita?
Thank you. Well said, Camille. So change can be difficult and at times can also be lonely. Our teams are small, and having the opportunity to reflect with others around what is happening can be a challenge when you don't have a robust group of people to reflect with. It is really, really important that you don't become insular while working through this time of uncertainty. My biggest advice right now is that it is okay to feel vulnerable, uncertain, and anxious with this massive change transformation underway, but do not internally keep those feelings within you. A huge part of leadership is finding like-minded individuals you can go to in order to get advice, guidance from, but are also active listeners when all you need is a forum to vent, have someone be an ear, or be vulnerable about what you are feeling. Adriana?
Thank you. I'm actually quoting from an article by Peter Senge called The Dawn of System Leadership. And in that, there were two quotes, not necessarily Peter's, but that he says, to lead means to step across the threshold and let go whatever might limit you in order to move forward and create something better than what you walked through in the first place. The other quote that I'm going to close with is, a great leader is when the people said, we did it ourselves. Over to Deb.
So I think in this transformation, there's a fair amount of onus on being open and creating trust for this to be successful. And when I talk about open exchange of information, I'm talking about the good, the bad, and the ugly, which becomes critically important as it does getting out of your wheelhouse to try and help address system issues that are not necessarily yours. Leadership, I think, comes from within. It's at the top, but it should also be in the middle, on the sides, and at the front line. And good leaders need to foster this. And I think with that, I'll just pass that over to Adrian.
Great, thanks, Deb. I'll be brief. It's maybe not actually. It's interesting being on a panel with all women. And because, you know, we all hear so much about the manels and we see them, and we're in a sector where there is a lot of women leadership, and I think that's great, and we need to see that as an asset and be championing other women. Also, challenge the status quo, be optimistic, take initiative, and most importantly, be kind.
Oh, some beautiful, beautiful advice from the leaders around the table. Very inspiring. Thank you so much. I'm going to just wrap up today's webinar. I want to leave you with this thought, that coming together is a beginning. Keeping together is progress, and working together is success. And I hope that you've heard some things today that will inspire you to work together in new ways. I also want to encourage you to participate in everything that Leadership has to offer. As I mentioned at the beginning, this webinar is part of a series, so if you haven't seen the others, check them out. They're available on demand on the website, leadershipproject.ca. You'll also find lots of resources there, some great articles to help you in your leadership role or as an emerging leader. And I want to also flag that on July 11th, there's a leadership conference coming up. So if you haven't heard about that or don't know the details of that yet, you'll find all of that on the leadershipproject.ca website, and I encourage you to go there. I want to remind you, just as we're closing out here, and thank you so much for joining us and for spending this past hour with us. I want to remind you that there is a short survey right after this webinar, and that your feedback really does help us make everything we do inside of the project more effective and more relevant to you. So thank you to all of the panelists who made time to be with us here today and for sharing their ideas and their insights and their inspirations, and thank you to all of you who participated today. Thank you so much for taking the time to focus on innovation and opportunity in our sector. Have a great afternoon.